Good afternoon. My name is Iris Bermudez, and I am the Director of the Centers for Medicare and Medicaid Services, Puerto Rico, and U.S. Virgin Islands Field Office. We're not a regional office, but we work like one. We work with our peers out of the New York Regional Office. I'm very pleased to be here with you all at the Somos and Futuro conference, and of course, I will be serving as moderator. To those of you visiting for the first time, welcome to Puerto Rico, and make sure you come back. To you veteran visitors, welcome back. No, leave your money here. Mucho. And to those of you who live and work here, don't plan on leaving. We need everybody to stay here to help us work out our problems. Okay, a little background before we start. As most of you know, there were approximately 47 million people living in the United States. 16% of the estimated 300 million population did not have insurance, and 10 million people, 22% of the uninsured, were not citizens prior to the implementation of the Affordable Care Act. Lack of insurance disproportionately affected Hispanics, who accounted for 33% of the uninsured population, but were only 15% of the US population. And I'm sure I'm not telling you something you didn't know already. Fast forward to an article that just came out October 27th, written by the New York Times, entitled, "Is the ACA Working?" The authors state that after a year fully in place, the Affordable Care Act has largely succeeded in delivering on President Obama's main promises, but has fallen short in some ways and given rise to a conservative backlash. The article reports the number of Americans without health insurance is down by about 25%. 8 to 11 million people have insurance coverage, and at least as many have enrolled in Medicaid. And we do know that because of the open enrollment period, the experiences we had with the system and all that. But we went beyond the 7 million that we were expected to enroll in the Affordable Care Act. Families USA reported that there was a short decline in the uninsured rates for Latinos in Medicaid expansion states, and that according to the Commonwealth Fund Affordable Care Act Track and Survey, the overall Latino uninsurance rate dropped from 36% to 23%, less than 1 year after the first enrollment period in the marketplace. And as you know, we're all preparing to go into our second year of enrollment. Now, according to the Congressional Budget Office, the law is projected to expand coverage to millions more, but it will not eliminate the problem of the uninsured. As you know, millions are caught in policy gaps. Some are difficult to reach due to mental problems, language barriers, or isolating factors. In another article issued October 2014 by the American Institutes for Research, entitled, "A Little Knowledge is a Risky Thing, Wide Gap in What People Think They Know About Health Insurance and What They Actually Know," conveyed that while coverage is a key to accessing affordable, high-quality care, consumers who struggle to understand how health insurance works and how to estimate their out-of-pocket costs are at risk of going without needed care, even if they are covered. With us today to talk about the Affordable Care Act, implementation experiences, challenges, and opportunities are the Honorable Michael Blake, New York State Assemblyman. Ellen Vollinger, legal. Looks like you're well known, Ellen.
You're my promoter.
Helen Schwab, New York State Policy and Legislative Director. Judith Sheridan-Gonzalez, President of New York State Nurses Association. And Manuel Perfecto, President, Union General de Trabajadores, 1199 CEIU. Okay, we'll be given each panelist 10 to 12 minutes to do their presentation, and we'll entertain questions during their presentation, but only 3-word questions are allowed. No, I'm not kidding, I'm only kidding. Just don't make it a big, huge paragraph, so we can answer your question as soon as possible. And then at the end of all the presentations, for those of you who didn't have an opportunity to ask your questions, we will be doing a Q&A session, okay? So, where do we start? With Assemblyman Blake. Yes, if you want to.
Good afternoon, buenas tardes. I thought I'd get more energy after you just had lunch, didn't you? Good afternoon. You know, we need buenas tardes, damas y caballeros. We need to get some coffee in here right now, you know, or maybe maybe folks were having too much fun last night. That was going on right there. Good afternoon to everyone. My name is Michael Blake, and newly elected Assemblyman of the 79th District in the Bronx, New York. I'm gonna bring Carmen with me everywhere we go. That's how you know everybody has to have one person itself, and obviously this is an issue of personal importance for me for a few different reasons. Number one, my family, healthcare and health issues have impacted me in many different ways. Both my parents were touched by cancer. My father succumbed to cancer last year. My mother's breast cancer survivor. Several of you are aware, my daddy worked for 29 years at St. Barnabas Hospital as a proud member of 1199 SEIU. In which, things came full circle. My first job was as a teen youth counselor at St. Barnabas Hospital, and then I came back around to now be the Assemblyman representing St. Barnabas Hospital, right? So that's a blessing when things come back full circle. And prior to this, born and raised in the Bronx, New York, which, if you may not be aware, the U.S. Census has indicated several times there is no more diverse area in the United States of America than the Bronx, New York. There is an 89.3% likelihood that the next person that you speak to is of a different ethnicity of the previous person. There is no area in the country that has a diversity threshold that high. And so, why is this also important? Because prior to this, I was working in the Obama administration, directing minority business outreach under President Obama itself. And one thing we would say all the time, they talk about this term of Obamacare, and we got to the point where we were very playful about it, in which we would say, you would rather have someone who says Obama cares rather than someone who doesn't care. Because, the Affordable Care Act is transforming lives in a very tangible way. And if I might, allow me just to very briefly touch on some of the challenges, but more importantly, the opportunities and how we move forward itself, specifically, and what are we talking through within our Latino communities. So, first and foremost, I think overwhelmingly, the challenge is not, are there quality programs? The reality is that people may not be aware of how to get to them, and creating the opportunities for them in many different ways. If someone is dealing with the challenges of, I have kids to feed, I have a job that gets out late, I'm not trying to have a conversation with you about preventative care right now. Too often the preventative care, someone decides I'm gonna go to an emergency room rather than going to the community health center. In so many different instances, and the nonprofits that have the access in that manner. But when we think about what is happening right now, a few different data points, because that you sometimes hear that the Affordable Care Act is not working when it's quite honestly the opposite. With all initiatives, there's obviously more room for growth, but there's clearly progress. In just 1 year, the adult uninsured population of Americans dropped by 26% because of ACA. 10.3 million fewer adults were uninsured at this same date a year ago. Just putting that into context in terms of the growth that has happened very, very quickly in that manner. And when we leave from here, us being cognizant that we do have a responsibility. The open enrollment period begins November 15th through February 15th. So literally when we go back, we have an opportunity very quickly to educate our respective communities on what that opportunity may be for them. A few other data points that are important. 76 million Americans with private health insurance can get preventative services. Specifically, out of that 76 million, 8.8 million Latinos and specifically 4.9 million Latinas who are able to get data and able to get preventative services that they weren't able to get before. Now, this is obviously one part of the premise. How can you be aware of the preventative opportunities that are out there? But then beyond that, specifically for seniors on average saved $1,400 on prescription drugs. Too often we would have the conversation that our seniors were deciding between prescription drugs and their groceries. That should not be a consideration. You should be able to do both and be able to achieve both in that same manner. You often hear from those that are in the business space, and I've been in business in multiple different ways, working at Green for All and Operation Hope, et cetera, that this is going to be a job killer. It's not going to work for us. We can't do this. In the same conversations we have around raising the minimum wage, that's a choice that an employer should be doing and doing the right thing. We've had the slowest growth in prices in healthcare goods and services in nearly 50 years. We're seeing from a clear data point that this is obviously happening in that manner. Another point, which is powerful and resonates, there were 150,000 fewer unnecessary hospital readmissions in a year span. Now, again, put this into just real practical impact in your livelihood. Too often, someone is going back to the hospital for things that should have been addressed in the first place, right? Come on, talk to me, right? And what we see happen, and you can also tell I'm a preacher, right? You probably picked up on that by now, right? Too often, we are not addressing all the causes and root concerns and having that collective conversation, and equally, the responsibility on us as individuals. If someone is telling you, here are the things that you need to do to get better, and then you don't do them, what do you think is going to happen? You're going to end back in. However, what we've seen because of an increase in preventative care, which has been documented over and over again, if we take the steps on the front end, we can address things on the back end not being the case. Diving in a little bit deeper, 1 out of every 3 patients at a community health center in this country is Latino right now. 1 out of every 3. We have a responsibility in understanding the impact in our respective communities. That means someone is not immediately rushing to go to an emergency room. They actually want to find that local center. Why? Because of cultural sensitivity. Let me put this in a practical scale. The district that I represent in the South Bronx, it goes from 153rd to 183rd. We have the largest West African population of anywhere in the world outside of West Africa is in my district. Right? So when we talk through conversations about cultural sensitivity, I have to be cognizant that the languages and how I communicate to our respective communities, especially if French is not out there, I'm actually creating a barrier to our communities. And we all know that too often, if someone's making a determination, the emergency room, the hospital, that seems scary to me, but I will trust that health center that could be there and provide that access point. It changes the opportunity and obviously creates a space for us as well. Now, obviously, we've seen some positive growth, but we also be cognizant of other entities. About 31.9% of the Latino community were obese in 2010 versus 26% in non-Hispanic white communities. So obviously we have some progress that needs to occur in that manner. As many as 1 in 4 of the U.S. uninsured population is Latino, even with the opportunities that exist right now. As many as almost 25% of the uninsured communities in the Latino community. However, 913,000 Latino adults, young adults, ages 19 through 26, now have coverage under their parents' plans. Let's break this down. Almost 1 million young adults have access who otherwise didn't have access before. And so when we have these conversations, when people are talking about the Affordable Care Act and why is this beneficial to us, well, let me try this in a real, tangible way. Raise your hand if you have a child that is under the age of 26. Anybody in the room? Okay. So your child can get coverage under your plan. How many of you believe that your child truly understands that, though? A lot of our young adults still think they're invincible, and think, oh, it's okay, I don't need health coverage, and sure, I'm gonna use my skateboard and just go on down the hill, right? Like that's not a good scenario for success in any way, but how we talk that through. 11.8 million Latinos no longer have lifetime or annual limits. That's a game changer itself. And so where do we see as the opportunity? I think there are many different opportunities that present themselves, and ironically enough, some of us were just having this conversation at lunch, and it was very timely around this. Number one, there's a clear economic opportunity across all of our communities. You know, my background is in urban entrepreneurship and minority business growth, and how do we talk through access to capital, access to contract, and access to opportunity. Health IT is a game changer, you know, and what's happening with medical records is a game changer. And the reality is, what happens too often in our respective communities is that we know that there's a job and we know there's an opportunity, however, we're not connecting the training and the preparedness to get someone ready for that opportunity. You know, many people may not be aware, when you go back to the States, Section 3 is an entity that HUD created, you know, essentially about, 20, 25 years ago, that in NYCHA developments throughout the city, if federal funding comes to those developments and there are projects that are happening there, they are actually mandated to create preferential opportunities to hire people in those communities. So how are we not creating that same opportunity to have workforce development to create opportunities for those that are getting ready as it relates to technology? That just makes sense. We see the growth that's happening. And for all of us that are here, whether they're here in Puerto Rico or going back into New York, the shareable economy is real. We have to be training our young people in all of our communities to be prepared about this technology, and that's there. That's number one. Number two, how do we create better positive messaging around the Affordable Care Act in its entirety? When you look time and time again, the data proves it over and over again. There is a higher threshold of support of the individual components of the Affordable Care Act rather than the act in its entirety. Why? Because we've essentially been created to be scared of Obamacare. But when you ask someone, well, what part of this would you actually want to eliminate? Would you want to eliminate free preventative care? Would you want to eliminate free mammograms? Would you want to eliminate free colonoscopies? Would you want to eliminate a young adult staying on their parents' plans until 26? Would you want to eliminate the donut hole being closed? No, 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 no. But what do you think about Affordable Care Act? Oh, I think that's terrible. No. So we have a responsibility to educate our respective communities in all different aspects of, let me break down for you the specific elements of this and concretely how you get access to it. Because too often we're having these conversations and someone says, I still can't get there. Last two things, and then we'll sit on down. First is, how do we educate on the causes and the remedies? You know, there's not much that can really transform in our community if you keep telling someone about the problems. You know, you have to talk about the problems, but also show the promise. You know, so here are the challenges, here's what got me here, but let me show you the way we can remedy these causes and the affordable way to do that. You know, you can't continue to have a conversation with someone and communicate to them, well, you need to get better, but you probably can't afford those costs. Let me eliminate that conversation for you. Let me show you how you can get better and it can be affordable for you at the same time. And again, we have that responsibility and we're seeing that growth opportunity that's there, and that's what ties me to my last point. We have this collective space, and I think we've been, you know, in many different ways talking about what happened on Tuesday. I'm actually more optimistic on what happened on Tuesday for a few different reasons. Tuesday proved yet again that when you don't educate people about the consequences of actions, what happens? Okay? Turnout was down on Tuesday, everywhere. Right? So that's not a wave. That means people weren't motivated because they didn't understand the consequences of inaction. Right? So what that provides is an opportunity to say, let me educate you about the tangible things that are happening in your respective lives, and then you make a conscious decision what happens from there. And so what we have in the next 2 years, which I think we need to be very cognizant of, is we leave from here in 15th through February 15th, we have a 4-month span to educate people about open enrollment and educate them on bills are going down, people are getting healthier, there's more access. Let me eliminate the boogeyman. I have not heard anyone talk about a death panel in about 2 years. Right? The things that we're trying to scare folks away in our communities about from the respective opportunity, and how do we partner up with our nonprofits that are doing great work on the ground. There are a lot of entities that have the resources that just need to get the support to actually implement that. We don't need to recreate the wheel. It doesn't make sense. If someone's doing it well already, I'm gonna be very self-serving for a second. VIP Services is doing phenomenal work in our community, right? We see this all across the board. When we talk about gun violence, Save Our Street with Hakeem Yamadi is doing incredible work already. When you have entities, let's partner up the resources with those entities to actually make this real and tangible in that particular way. So for me, the Affordable Care Act presents, obviously there are challenges and there's a question about that, but we have to be cognizant that there's a bigger, broader opportunity that's being presented right now of helping our communities to grow and to live much longer. Why do we need to care about this? A few different reasons. By 2043, if not earlier, people of color will be the majority in this country. Every single month right now, 50,000 Latinos are turning 18. In Texas last year, at the end of last year, there were more babies of color born than white babies for the first time ever in its history. We're seeing this growth that is happening, right? This is happening in our respective communities, and we have to make sure we're engaged in this manner and educate around the policy components in all different aspects. What happens in education impacts your health care. What happens with job security impacts your health care. What happens with raising the minimum wage impacts your health care. What happens with the DREAM Act impacts our health care. All of this is intertwined to understand the urgency of the opportunity, and that's why we should be excited about the opportunity, not focus as much on the challenges, and look forward to hearing any and all of your questions at this time. Thank you, everyone. We can do questions, or we can wait. I've talked for a while, so please, we'll take two questions, and I'll sit down so the rest of the panel can go. Please.
Just a quick question. I'm Senator Juan from Long Island, and one of the problems I'm hearing is Assemblyman Elector, one of the other panelists, the workers in my community are concerned because they're obviously paying the Affordable Care Act funds, towards the taxes, whatever the Supreme Court decided, but they feel like they're going into the bronze plan as opposed to the silver and gold,
Yep.
big deductible.
Yep.
Big, $6,000. And so they are not being reimbursed when they go for the medical care, so they feel like they're paying more and still not getting.
Not getting quality.
But that's the biggest problem I'm hearing out there right now.
No question. There's an entity that is called Enroll America that I'm happy to partner up with anyone about this, which a big part of their goal is to address this, of educating communities about the different plans that are available and showing them that, and I even went through this exercise intentionally myself. You see one bronze plan, you see, okay, well, this doesn't actually work for me. But if I keep going until the next few options, they're actually bronze plans that will be more economically affordable for me and actually work out in my best interest. But what happens, again, because of collective cultural sensitivity and challenges, we see that first plan, that doesn't make sense. We don't continue to look at the other options as well. So Enroll America is a phenomenal entity that has been created. Ann Filippic is president. Would love to partner up. Obviously, can't wait to work together in Albany for that awareness of saying to our communities, don't be scared off by this first option that you may see, where you're seeing, well, wait a minute, I'm paying, but I'm not getting the quality that I actually could get. If you continue on that, one thing I saw that was fascinating. Several of these plans themselves, someone would see one plan and say, okay, I'll get a lot of dental coverage, and that's good, but I don't really need that. Let me go to the next plan, which may be a bronze plan, and I'm actually going to get a better deductible and more of the coverage that I actually want. And so we should work through those options, and we definitely can. And Enroll America is one of many entities that can help address that. Please.
Yeah, my question is somewhat similar. The bar is very high
Yep.
for folks actually, that will get subsidies.
Yep.
So I have a lot of people coming to me because I'm in the healthcare workers union. They figure anybody that gets anywhere near a hospital is an expert on healthcare. And I get a lot of calls from friends outside of New York City that live in Westchester County. I'll give you an example. They don't know where to go to find a navigator
Yep.
to help them wade through this.
Yep.
Young woman, acupuncturist, recently divorced. The son is still covered under the husband's plan.
Yep.
They had Aetna. They had excellent coverage. She now is trying to wade through, to compare plans to find one that is affordable to her. I know the Community Service Society has been very helpful to folks in New York City area, but I was going to ask if you knew of navigators or organizations that can help folks that are not necessarily entitled to a subsidy,
Yep.
but to help them navigate to find an affordable plan.
There are a few, and we definitely should talk through them tangibly. National Association of Health Service Executives, that's the Jamaican in me, I start talking fast sometimes, right? National Association of Health Service Executives has actually started out a program as well, specifically on this, how to create more awareness about the navigators that are available within particular communities. and making sure that it has multiple languages that are available to folks. You know, too often someone was just showing up in a community and it was English only. That doesn't really address the challenges that we have collectively in our communities. That's one. Two, it's important for all of us to make sure that we can't let someone get scared off by the possibility of an upfront cost. We have to actually educate them as well of, if you don't get covered in any way, your expenses are going to be even more paramount. You know, the bankruptcies and the impacts that have been collectively happening with our communities because someone is making a decision, I'm not going to get covered at all. And so, okay, you know what, we may be paying a little bit more upfront. We can find you subsidies, find you different options on this, but the alternative of not getting covered at all is actually significantly worse. So we can, again, partner up. There are several entities that are working on this, Enroll America being one. I know I mentioned that earlier, NACI being another. I actually partnered up. There was about 7 of us that did a navigation tour earlier this year, and we were going primarily throughout the South Bronx, but we went to a few other places throughout the city in Harlem, Washington Heights, et cetera, with Russell Simmons and Tamika Mallory and others. So we should definitely sync back up on that once the enrollment period begins again on November 15th. Perfect.
Thank you. Thank you. Okay, your questions are getting kind of lengthy, so we're going to kind of speed up this because we only have not too long to do the other presentations. So Ellen, you're next.
Well, it's a little tough to be following the Assemblyman, who I think gave us a great start. I just want to thank Somos Futuro for having us, and Assemblyman Felix Ortiz in particular, who always sees connections between health and nutrition and hunger. And I come from the hunger community, the Food Research and Action Center. And a shout out, because I know many of you are from New York, because New York has taken a lead on a lot of hunger and health issues, one of which is to fund outreach for nutrition services, including for the Supplemental Nutrition Assistance Program, what used to be food stamps. Governor Cuomo took the leadership to preserve $90 a month in SNAP food benefits from the federal government for everybody on SNAP in New York State, where that would have gone away. And in New York City, the city, with leadership from the mayor, the city council, the public advocate, is now making sure that all kids get universal school meals. And I raise that because as households look at how they're going to purchase care under the Affordable Care Act, making sure they have all of their other needs met will make that a more affordable choice. So kudos to New York for that. We're not experts in the hunger community on ACA, but we are experts on why it matters to hungry people. Food insecurity is too high in the country, and it's particularly high for Latinos. That means people are wondering where the next meal is going to come from. They're facing choices about how much food they can afford, how much they can serve, whether they're going to have to miss meals, or even if their kids are going to miss meals. And in 2013, almost 1 out of every 4 Hispanic Americans was food insecure. It was particularly tough if they were Hispanic families with kids. That was 28% of those families being food insecure. So as Assemblyman Blake mentions, when people are facing choices between food and medicine, it's particularly acute in the Latino community, and it's a terrible problem. Feeding America is an organization that many of you may not know by national name, but I probably think you know their local affiliates in your communities because they represent the food banks across the country. And it's the food banks that get the food to the food pantries and soup kitchens, which often are the places that hungry people are going and learning not only how to get emergency food, but how they can get other services, nutrition benefits, but increasingly where they can get connected and get help navigating the ACA system. And for Feeding America, 1 out of every 6 of the clients that needed emergency food and came to them last year was Latino. So making connections between the hunger community, Latino community for ACA, I think is pretty much a no-brainer. We know that those clients who turn to emergency food have particular health problems. They've been surveyed, and this is what they tell Feeding America. 47% have fair or poor health. 24% of those households have at least one member other than the person answering the survey who's in poor health. Prior to ACA implementation, so hopefully things have gotten better, but prior to ACA, 29% of client households going for emergency food had no health insurance, including Medicare or Medicaid. And even those who had insurance were accumulating medical debt because they've got deductibles or uncovered services, and over half of the clients turning for emergency food had unpaid medical bills. So that acute struggle to cover basics is very, very tough. What they told Feeding America is that 2/3 of them faced a choice between paying for food and paying for medicine or medical care in the past year. And for a smaller slice, almost one out of every 3 faced the trade-off between food and medical care every month. So it's not a sporadic, one-time problem, it's acute. The food programs are helping people be able to afford some of those choices, but there are gaps even there. SNAP, which is the basic nutrition safety net, only provides people, on average, $4 a person a day for food. It's not enough, more needs to be done to help that. But many Latinos, particularly those who live in households with immigrants, whether they're legal immigrants or not, are missing out on SNAP. Some of that has to do with restrictions, but some of it has to do with fear of connecting with those services. And of course, we've already heard many Latinos are missing out on the ACA. And some of the questions that went to how do you help people understand how to navigate are particularly what's been pinpointed as a barrier for the Latino community. Survey for, I was glad to hear the Assemblyman mention Enroll America, because they did a survey earlier in the year about what happened during the first enrollment period for ACA. And it was Latinos and young adults who particularly lagged behind ACA in knowledge about ACA, but in fact wanted coverage. And Latinos who did get enrolled were more likely to report that they'd had in-person help. Again, those navigators, people that can get you the information. The education, as we heard from our moderator, is going to be very key. It's key for everybody, but it turns out it's even more important in the Latino community. So we care in the hunger community about getting people connected with ACA. We think there are strategies to use the hunger safety net to help do that. We also think, and we've heard from our moderator and Assemblyman Blake, about the importance of prevention for healthy outcomes. And we think hunger and nutrition, addressing hunger and through nutrition can be a way to do that. But also something we've heard a little less about that we're excited about for state services, human services delivery, is that CMS is working with its partners in the Obama administration, particularly USDA, to integrate some of the computer systems and some of the eligibility determinations so people can get more than one benefit with the same information. And we think that's great. We are hoping for even more progress in helping people get connected between SNAP and Medicaid. So going forward, I guess I would leave you with 5 takeaways of what I hope those of you who are working on ACA and want to see progress happen, that I think you could look to the hunger community to partner with. Number 1, we're going to keep our voice strong on why ACA is needed. The case was made, Congress passed it, it's been signed into law, but nothing's ever done in the federal government, nothing's ever done in Washington, D.C., and the case will continue to have to be made. And I think the anti-hunger community can be a voice that helps connect some of those dots and helps put a human face on who are the people that are struggling and why is this so important and what a difference it's made for people who've gotten it. Second of all, I think we can help get clients connected. On the sort of wonky side, we have people who are working with the wonderful policy tools that CMS has given, which is to take the information about people who are enrolled in SNAP, the old food stamp program, taking that information, and if states want to, they can use that information to get people enrolled into Medicaid. That's a huge opportunity, and frankly, the better job we do on outreach into SNAP, the easier it's going to be for that particular policy door to work. The third is that, as I mentioned, there are these efforts to modernize and integrate services so that it's easier to get more than one program with the same information. Kudos to the federal government, the Obama administration. CMS recently has extended permanently the extra dollars that New York State and other states can pull down to make those computer systems and eligibility systems work. It's a 90-10 match rate. Pretty darn good. And they've continued for several more years the opportunity for states to pull that down and not have to worry about how they parse out the costs among the various programs like SNAP. Fourth, our community is particularly interested in one aspect of ACA I haven't heard discussed much yet, but that is nonprofit hospitals doing community-based needs assessments, and we would very much be interested in working with communities on including food security measures as part of that assessment. And lastly, and this is where I'll end, on the navigators, many of the nonprofit groups across the country that are doing navigating, some actually are contained in the hunger community. Examples would be the Statewide Association of Food Banks in Ohio, and one I'm going to delve a little bit deeper into is a small food bank but doing great work in New Jersey, the Food Bank of Monmouth and Ocean Counties. Now, they've gotten notice from FRAC because we've worked with them for many years, but in addition to that, Stephen Colbert decided to make fun of the ACA and make fun of navigators, and where did he go visit? He visited Carlos Rodriguez, who's the executive director. And by the way, if you ever Google that, you'll find a better explanation of ACA than I can ever give. But that group did get funding for the first year to be a navigator. They're not going to be getting special funding to be a navigator second year. They're going to continue it anyway. As one of the people there emailed me, quote, "We strongly feel that ensuring our clients have access to affordable health insurance is an important means of promoting food security, and will continue to assist with enrollment again this year." They're going to sites where they take SNAP applications, other information. They're a trusted messenger in their community. They're trained to help people walk through these materials. So, but if you do want to see just somebody take on Stephen Colbert and win out and give ACA a pretty good profile, I'd suggest you go there. For any more information about FRAC, you can certainly go to our website, www.frac.org. But thank you so much for having us, and I wonder if we might want to take questions later to get through the panel. Yeah.
Okay, next to the podium is Helen Schwab.
Hope okay. You'd like the Colbert footage if you can see it.
Good afternoon. I was really tempted to rip that tablecloth off and wrap myself in it because it's a little chilly in here, but I'm going to try to do this without that. So I wanted to talk a little bit about another aspect of access to healthcare, which is really our healthcare delivery system. I mean, I know a number of people have touched on the importance of obviously giving people health insurance so that they can afford to seek care. But then there's another question, which is once you're seeking care, where are you seeking care and what kind of quality services are you receiving? And we know that even though we've made a lot of progress, there is a long way to go in terms of our healthcare delivery system. And people have talked about the outcomes, particularly in the Latino community, around diabetes, around cancer. You know, diabetes mortality rates for Latinos are 50% higher than for non-Latinos. So we know that when we look at outcomes, we're spending a lot of money in our healthcare system, but we are not getting the results that they are frankly, in the rest of the world. All of the rest of the industrialized world does better in terms of mortality rates than the U.S. as a whole. And then when you look at specific populations within the U.S., things are even more serious. So how do we address that? Well, the Affordable Care Act and actually some of the Medicaid reform work and the new Medicaid waiver in New York are trying to address that by transforming our delivery system, trying to move more care into communities to do preventative care. I mean, we really have always had kind of a sick care system, right, where we wait for you to get sick and to come to us. And we can provide, in a lot of cases, extremely high quality care when people get sick and come. But if we're going to have an effective healthcare delivery system, we have to have a healthcare delivery system, not just a sick care system. We have to go out and help make sure people can stay healthy, that we can prevent illnesses and not just take care of people once they become ill, although that's obviously very important. So under the ACA, there are a number of incentives to encourage this transformation of the delivery system into a less institution-based sick care system and more community-based ambulatory care. There's a lot of great things about that, and you know, in New York with the federal waiver that we just got, there's going to be an increase in that transformation. It's going to kind of give it a kick and move it faster. So one is, how do we build this healthcare system to make sure that we really have access to high quality preventative care in all communities, as well as the care that people need if they do in fact get sick. And a piece of that, of course, is culturally competent care. which Assemblyman Blake spoke about a little bit in terms of the community-based healthcare centers, you know, the FQHCs, which are so, so important, but we have a long way to go to really getting to that place in all of our healthcare systems. You know, for example, if you look at the Bronx, only less than 10% of registered nurses are Spanish-speaking Latino professionals. Over 50% of the Bronx is Spanish-speaking Latino. So how are we going to get to a place where people who are seeking care are able to see particularly healthcare professionals who can speak to them in their language, who understand the food culture, who understand the other cultural dynamics that are going to affect people's ability to follow treatment plans, to support their own health. We have tried to address that with a project called the Bronx Collaborative, which is 1199, the healthcare institutions in the Bronx, and CUNY, to help rank and file healthcare workers, non-professionals, go on a career pathway. We have support in terms of college access. For example, you know, helping people study math in a healthcare context to help them pass the CUNY entrance test so that they can begin getting a professional degree in healthcare, getting their RN or other types of professional degrees. It's getting to the college access and also reducing the time to degree completion by making stackable credentials. So I can get one step while I'm working, then I can keep going to the next step. So that's one example of trying to address through the healthcare delivery system some of the challenges that we have in terms of making sure people really have access to culturally competent care, having the workforce in place who is able to deliver that care and at the same time helping individuals raise their wages and move forward in their careers. Another example, this is in the institutional setting, but in nursing homes, residents are increasingly becoming more Latino, but much of the healthcare workforce in the nursing homes do not speak Spanish. Right? So you have a situation where somebody needs support when they're elderly. This is now their home, but many of the people who are caring for them can't really communicate with them very well. So we have a language program for nursing home workers to help them learn Spanish in that context. We know, particularly in unionized homes, there's not a tremendous amount of turnover, so we need to help the workforce there be able to provide care and support to the residents who live in those homes. Just want to say a couple of other things about both the good things and the bad things about how our delivery system is changing. So we have, you know, now, as I said, good incentives to move care out into the community, but we think that there are some concerns and some dangers about that as well that we're going to have to address in the process. One is, you know, the payment reform, which is encouraging this community-based care, trying to address some of the excess costs in our system, is driving a huge wave of consolidations in hospitals. You know, people see it every day. There's mergers, this one is taking over that one. The community-based hospitals are going to have a hard time existing and staying as they are, isolated without being part of a bigger network. And it may be that it makes sense for people to be part of a bigger network, but if that happens in a way that destroys those community hospitals without anything to replace them, you are really going to reduce healthcare access in very vulnerable communities. We certainly see it in Brooklyn, we see it in rural areas upstate, where you have these standalone community hospitals not surviving or having a very difficult time surviving with this payment reform. And the danger, of course, is that they collapse before there is anything to support them or to replace them. So we're very concerned about that, and that has to be an important part of how we address healthcare reform. The second thing we would say is that when you move into the ambulatory care setting, we have great FQHCs, we have great community clinics, but ambulatory care as a broad sector is actually more segregated, we would say, than institutional care. In New York State, Medicaid is actually a pretty good payer inside a hospital for inpatient care. The big hospitals, not that there is no discrimination or patient steering, it certainly exists, but the big hospitals do not have a lot of incentive to turn away Medicaid patients because they get paid reasonably well. But that's not true in the ambulatory setting. So you see much more private doctors' practices do not take Medicaid, you have overcrowded clinics, that's where the Medicaid patients go. So as we move more people into the ambulatory setting, we really run the risk of moving them into a segregated healthcare system, which could really affect the quality of care and access, and that's something that certainly has to be addressed. And the last thing I would just say is that we know, as the union that represents hospital workers and community workers and nursing home workers, lots of different healthcare workers, that the wages and benefits in the community care sector, broadly speaking, are significantly lower than in the hospitals. And as we move more care into those settings, we have to be very aware of that, because over time, you could certainly see the jobs shift, the number of jobs in institutions going down, the number of jobs in that other setting going up. And really, when you consider the size of the healthcare industry in New York State, you can see an increase in income inequality. Frankly, if we've moved a bunch of middle-class jobs into much lower paid, lower benefited jobs. And that's something we have to address, because income inequality and inability of people to make a living and to support their families is certainly something that directly affects people's health. So as we seek to improve health, we don't want to work against ourselves in that way. So I'll leave you with those thoughts, and we can talk after that. Thanks so much.
A lot to think about. Thank you so much. And next we'll have Judith Gonzalez.
Just gonna put up a PowerPoint here. Let me see, maybe those in the front, you may want to turn your chairs around. Okay. Hi, I'm Judy Sheridan-Gonzalez. I'm president of the New York State Nurse Association. We represent 37,000 nurses in the state of New York. I'm an ER nurse. I still work in the Montefiore Emergency Room in the Bronx. We are the busiest emergency room in the state. So I'm a frontline healthcare worker. I think I'm going to give you a little bit of a visual of what you've heard, actually a little bit here. When we talk about healthcare disparities, we think of diseases of poverty, and in the world, we think of malaria, typhus, malnutrition. But in our city, we also have diseases of poverty. This is a street in the Bronx where I work and where I live. We were talking about overcrowded primary care centers. That is what you're seeing. When you talk about primary care, you have to have the hours, the facilities, the space, and the access. That's not the case right now. And where do a lot of those patients go? To my emergency room. And this is a pretty typical picture of the emergency room. Looks a lot like that clinic in Haiti you saw, right? Very crowded. We have more technology, but the overcrowding is extraordinary. Just some visuals of the statistics you heard. Diabetes, how it affects our community, and among Latinos, Puerto Ricans have a higher level of diabetes. When you think of diabetes, you're not just thinking of high blood sugar, you're thinking of the complications: heart disease, stroke, high blood pressure, loss of limbs, kidney failure. Another scourge in our community is the use of alcohol. Again, we seem to have a little bit of an edge on that one. And complications. The community more at risk as a Native American community in the country. That was a gift from the Europeans. Also, obesity. Big issue. You see the darker area up in the Bronx, that's exactly where my hospital is. That's where I live and work, and we have the highest rate of obesity in the city. I'm sure those of you who ate those bacalaitos last night, thinking about that. Chicharrón de pollo. A lot of complications of obesity. Aside from the other ones you get from diabetes, you get gallbladder disease, cancer, and other gifts. So everyone going to the gym tomorrow, right? And this shows, poverty. Obviously, these are diseases of poverty with the additional piece of discrimination involved. And as Martin Luther King said, one of the greatest injustices in equality is healthcare inequality. Asthma, big issue in the Bronx. We have the highest rates of asthma in the nation. And again, you see that Bronx region, everybody sees the Bronx there? Highest rates of asthma. A lot of it's from pollution, And what this slide says, that Latinos are 3 times more likely to die from asthma complications than others, than Caucasians. And our Bronx region is very polluted. You know why? Anyone know what highway this is? Cross Bronx. It cuts our borough in half as people from New Jersey go back and forth to Connecticut, spewing their diesel fuel, these trucks spewing diesel fuel into the lungs of our children. People are fighting back, happy to report, a lot of community activity around that, and one key one is the Fresh Direct. I don't know if you've heard about this struggle against Fresh Direct. Fresh Direct delivers food to wealthier communities. In fact, they don't deliver to the Bronx, but they like to set up a distribution center in the Bronx and poison our air more. And people are forced when it comes to fracking, the XL pipeline, all these global issues. Well, do I want a job or do I want my children to die from these diseases or my water to be poisoned? We don't believe that that should be a choice that people should make. We'd like to see some green jobs. And there's a movement to boycott Fresh Direct, which is very linked to the climate struggles that are going on. This is a community garden, one of our green movements in the Bronx to take abandoned lots and convert them into organic farms. So what can nurses do? We're in the front lines of healthcare. We are a union. We're here to take care of patients from birth to death. Right now, we face incredible technological challenges that separate us from our patients, with people being very sick in the hospital. Right now, you go home one day with stuff used to take 2 weeks in the hospital to recover, and families are ending up taking care of patients. We're drowning in paperwork. I think anyone who's a health professional or professional in any area in our society is stuck with lots of paperwork, and we're subject to violence. We are at the nexus, at that point in which the healthcare system fails our population, and unfortunately, we're in the front line, and we are subject to being verbally abused, physically abused, kicked, spit on, stabbed, shot, and terribly injured. There's deaths involved as well. And when something goes wrong, being in the front line, you get the blame. So we have a big degree of burnout. This is actually, I've showed this slide to nurses, and I have to stop talking because they laugh so hard, because this is kind of what we look like at the end of a day. So we have a union. Unfortunately, our union years ago was not committed to social justice. We are. We don't believe that our role is just to defend the rights on the job. We have to defend our patients and our community and their right to access to care. A few years ago, our organization was dominated by people who were not at the bedside, who basically didn't really do very much. We took over our union, we won an election, and we are embarked on a campaign to educate, agitate, and organize. We educate our members about, I think if you heard earlier workshops, everyone familiar with these guys, the Koch brothers? Not only do they own Lincoln Center, they have a commanding share of New York Presbyterian Hospital. They are everywhere. They finance the Tea Party, they finance the elections. They're a big problem. And a lot of the changes we see in healthcare is really not about efficiency. It's not about running it better. It's not even about saving money. It's about generating profits for a lot of these for-profits and also these not-for-profits. And what happens? We close hospitals. In Brooklyn, where you have 1,000, for every 1,000 patients, you have 2 hospital beds. In the Upper East Side, you have every 1,000 patients, 6 hospital beds. Where are they closing hospitals? Brooklyn, where they're needed, not in the Upper East Side. They're building there. And unfortunately, with all respect to Michael Blake, there are some politicians that we have been betrayed by. And they get a lot of their...
I'm not one.
They get their funding from some of the same people that are funding the Tea Party. You know, the funding mechanism for elections, it's ridiculous. You have to have all this money to be able to win office. So there's a lot of money out there. They say they have to reduce spending. There's a lot of money out there, $180 billion in New York State alone. I think that's higher than half of the world's gross domestic product, half of the nations in the world. And as you heard, there's all these mergers and acquisitions. They're taking over everything. They have tentacles everywhere. I knew when Montefiore changed the name, Montefiore took over the Our Lady of Mercy. For those of you who know the Bronx, they called it Montefiore North. And all of a sudden I see it was called Montefiore Wakefield. I said, I guess they're going to move further north. Pretty soon we'll have Montefiore Plattsburgh, Montefiore Montreal. And look at where this money's going. Look at these salaries, tremendous salaries in the poorest community in the nation. You have 2 CEOs, one a hospital that's making money, one a hospital that's not. Look at their salaries. What else are they spending their money on? These superficial expansions, frivolous amenities. At New York Presbyterian, you get lobster and a rose on your plate if you have the right connections. And what's happening to the patients? They're not getting better care. I know it. I work there. And in fact, as they close beds, this is funny, but it's true. We have patients admitted to lounges, to hallways, on stretchers, in bathrooms, in toilets, in treatment rooms, and they're closing beds at the same time. We have, at the same time, people packed in admissions in the ERs, and that's an admission now. You can have your whole admission on a stretcher now. So the Affordable Care Act has had an impact. There have been some changes, as you heard. There have been some improvements, but we are seeing major problems with the Affordable Care Act. I'll tell you why. This is a really great cartoon describing what Mr. Blake talked about the lack of understanding about the Affordable Care Act. You know, somebody will say on one side, you know, they really love this, but they hate it. They don't, you know, these Koch brothers run Fox TV, Wall Street Journal, and so forth, so people are misinformed. So one problem with the Affordable Care Act is we still have these predators, what we call the insurance companies. And look at the kind of salaries they make. That's healthcare spending going to those salaries. And then, when you have insurance, all of a sudden when you need it, what do you find out? Doesn't really cover what you thought, right? I don't know anyone who had only 80%. It's a very small thing, the appendix, but. This is how a lot of people feel about their health insurance. And if you look at the costs, at the jobs that are open in healthcare, that bottom little, if you can identify that tiny little, that's providers. That's the increase in providers, people who are giving care. All the rest are people who have nothing to do with healthcare in terms of delivery. So this is what we identify as the problem in healthcare, that the Affordable Care Act does not remove, the insurance companies. And while people are poorer and having a harder time getting out of that rut of poverty, we have a vision. We call it the healthcare New Yorkers deserve. And we believe that healthcare is a human right, and we believe in a single-payer healthcare system, such as most countries in the world have. That would be improved Medicare for all, expanded. It would be really universal care. This is a long slide. I don't want to take up your time, but you can look at it later. It's on the Physicians for National Health Plan program. It talks about the differences in what you get for single payer and the Affordable Care Act, which is a step, but not going far enough. We would save money because the big issue is with single payer is it would be tax. So right now, a person who makes $12,000 a year has to pay the same amount of money for an insurance plan that a person who makes $12 million a year. With a single payer plan, that would be a graduated tax. In the state, we have a bill. Senator Gottfried has put forward a bill, New York Health, which we're supporting now after the election. I don't know how far we'll get, if we'll ever get it out of committee. But there is money. People tell you there's no money. This is $200 million a year the top 20 managers from the New York City hospitals make. I just really want to emphasize when people say there's no money, there's money. So we marched against that organization, the Greater New York Hospital Association. We call it the Hospital Corporation Cartel, the ones taking over all these other hospitals and making all this money and saying they don't have money to provide staffing. We link our patient care, patients before profits, with safe staffing. Those are two bills we're trying to push. Michael Blake, keep that in mind.
I picked up on that.
We see safe staffing linked to having better care as well as having a different healthcare delivery system. And we marched through the halls of Albany. We didn't take over the Capitol like the teachers did here, but maybe next year we'll do that. I don't know. We believe in direct action. And we're creative. This is our hospital. We weren't allowed to carry picket signs because there was some contractual issue, so we carried letters to get our message across. We have to be creative. We marched over the bridge to save interfaith with our colleagues from 1199 and the communities, and the struggle for Litch goes on. Long Island College Hospital, we're going to be left with something that's healthcare related, not what we wanted, but we believe in fighting the good fight no matter what. We're involved in the People's Climate March. Everybody heard about that? Look at that. Almost 400,000 people marched throughout from 86th Street to 34th Street, and we were there with our red on. think globally, act locally. Hurricane Sandy hit, that's our local response, a local issue that came up as a result, direct result of climate change. Nurses were there in the hundreds and thousands rescuing people. I'm a first responder, many of us were first responders, going up and down in dark buildings rescuing people. And certainly the Ebola crisis brings to mind that the global situation is very local. This is me in my Ebola outfit. We're going to be a receiving center. We recognize we're one people, and we have to take care of one another. Our families are most important to us. We do believe a better world is possible, and we are not going to stop fighting. Thank you.
And now, we save the best for last. Venga, véngase, véngase.
Bienvenidos a todos y todas a la nación puertorriqueña. Quiero comenzar, ¿verdad?, con una reacción breve. Si yo tuviese tres vidas, yo tendría tiempo para esperar quizás 2 siglos en lo que los políticos de turno, llámese como se quieran llamar, demócratas o republicanos, o populares o PNP en Puerto Rico, yo tendría 2 siglos para tratar de resolver el problema de la salud. Pero como lo que tengo es una sola vida, tengo que buscar la forma de resolver el problema ahora. ¿O puedes traducir tú esa parte que es más...
Good afternoon. Manuel, what he's trying to say is that he would like to have 3 lives so that he would have enough time to work on the health problems that we have here. But he has only 1 life, so we have to take the most out of it and work as hard as we can get.
Le pedí a uno de los compañeros de la Alianza para la Salud del Pueblo que me ayude, ¿verdad?, en la traducción. Yo no sé papita inglés. El problema que tienen ustedes es entenderme y el problema mío es entenderlo a ustedes. Quizás la mayoría de ustedes me entienden, ¿verdad?, porque hablan español, pero yo no hablo inglés. Por lo tanto, ustedes quizás me llevan a algún nivel de ventaja, ¿verdad? Pero a estas alturas del juego, yo me siento tan bien con lo que sé y con lo que he aprendido, que no me ha hecho falta el inglés, ¿verdad?, para poderme desempeñar como un hombre de bien. Bien. En Puerto Rico hay 3.600.000 seres humanos, individuos, que están en la llamada reforma de salud. Eso me molesta a mí cada vez que uno habla de reforma, porque se reforma, la reforma, se reforma, la reforma, y sigue reformándose lo que está virado, lo que no sirve. Lo que no sirve no se reforma, se cambia, se bota, se elimina.
Puerto Rico has 3.6 million inhabitants. Only 3.6 million inhabitants. Yet, we've had, since 1993, a lot of health reforms, and none of them has worked. As a matter of fact, right now, as it stands, we are spending much more money and we are not getting the results that we want.
Bien. El estado más pobre de la nación americana, de los de allá, que ustedes viven todos allá, y tienen familia acá, tienen una ventaja enorme. Mississippi, la pobreza son 36.850 dólares promedio anual. Puerto Rico, el nivel de pobreza son 11.000 dólares. Eso quiere decir que el más pobre en Mississippi gana 3 veces lo que gana un pobre en Puerto Rico. Y claro, la imprenta de los billetes verdes está al lado allá. Y con todo y que la imprenta de los billetes verdes está al lado allá, toda la información que han provisto los hermanos y hermanas en términos de las condiciones que vive el pueblo americano es espantoso. Es espantoso.
The poorest state of the nation is Mississippi. Yet, we have only 1/3 of the income of the poorest people in Mississippi. Now, what are we going to do about it? Right now, the per capita of insurance in Puerto Rico is $3,324 per person. We spent 12 billion with a B. We spent $12 billion. That represents 18% of the budget of the island in health to cover what they call Mi Salud. That's the government plan for the poor people. Private plans like Blue Cross and Blue Shield, Humana, and whatnot. Medicare, ACA. ACA is the no-fault automobile insurance plan that we have. I don't know whether New York has one, but it's working here since 1968. And the Fondo Seguro de Estado, that's a workman's compensation fund. All of them, the 5 of them, spent $12 billion for health that is not working as it should.
Bien, Puerto Rico invierte el 18% del Producto Nacional Bruto, 18%. Estados Unidos invierte el 17%. Si uno pusiera eso en una balanza, en una báscula, o como le quieran llamar, para ver por un lado la inversión y por otro el resultado de la inversión, encontramos que la balanza está inclinada de una forma desproporcional a favor de hacer rico todos los días más a las casas acreditadoras. Y escuchaba cuando hablaban de la cuestión de educación, la importancia de la cuestión de la educación. ¿A quién no le conviene que la educación se fortalezca? No le conviene a los que viven de la salud. Pues no quieren que tú te cures. No quieren que tú te cures porque ellos con eso pagan el Mercedes, con eso pagan el yate y con eso pagan los viajes que tienen, etcétera. Las condiciones de los puertorriqueños en términos de la situación de salud la estaba describiendo uno de los compañeros y están ahí. No tenemos que explicarlas, están ahí y como cuestión de hecho. No sé si trajeron copia de la presentación, la queríamos compartir con ustedes. Y si ya se la tienen, muy bien, muy bien. Seguimos. Tuti.
The same health problems that were stated here by the previous panelists are exactly the same problems that we have here. Now, what are we going to do about it? We have heard what in the Bronx and in New York are working, but what here on the island are we going to do about it?
Bien, la próxima lámina. La salud y la seguridad social. En Puerto Rico creamos una organización que se llama Alianza para la Salud del Pueblo, que es una organización multisectorial que ha impulsado, entre otros mecanismos, un sistema de salud universal. ¿Qué le pueden llamar? Y están aquí también 2 doctores más del grupo nuestro, ¿verdad? El doctor Juan Fernández, la doctora Judith Jackson, que es parte de la Alianza para la Salud del Pueblo. Hablamos de un sistema universal de salud y le pueden llamar como le quieran llamar, socialista, comunista, comemista, habichuela, arroz, lo que sea que le quieran llamar. A nosotros no nos importa cómo le llamen, es cuál es el alcance de ese proyecto. Y que es un proyecto que lo que persigue es que todos los seres humanos, desde que es concebido, tenga el derecho a tener una calidad de salud adecuada, desde que lo conciben, coño, hasta que se muere. Uno tiene el derecho a la vida. Uno no puede permitir que vengan los buscones, como se da allá y como se da acá, que nos quitan lo único que tenemos nosotros, lo único que es tuyo, que no es ni de tu mujer, ni de tu marido, ni de tus hijos tampoco. Es tuya. Es la vida, es la única vida que tú tienes. Y nos las están quitando pedazo a pedazo. Bien, Tuti, estoy emocionado. Yo soy igual que Minerva, que tenemos pique. Dale.
He's mad, and rightly so. Listen, what are we going to do about it? We have created an alliance for the health of the country. This alliance contains more different social groups than you can imagine. We have the physicians, the Physicians College or Association, as you call it. We have the dentists. We have the psychologists. We have the social workers. We have the Methodist Church. We have the community programs. We have so many that right now, as it stands today, we have 34 different alliances. But nothing can be done here just by getting this group together. Why? Because of the insurance people. The lobbies of the insurance people is working against us. And whatever we want to do, the insurance people are trying to knock us down.
Y por supuesto estamos los sindicatos también, que somos parte de esa alianza a la salud del pueblo.
Yes, I forgot to mention that we have the syndicates also.
Para poder mover el proyecto, y las enfermeras. Tenemos las enfermeras y tenemos los médicos y tenemos los trabajadores sociales y una alianza amplia de sectores diversos de la sociedad. Y tenemos políticos también, ¿verdad? Sí. Y tenemos políticos. Aunque el problema de los políticos, desgraciadamente, es que siempre ven un solo horizonte, no ven otro, ¿eh? Ven el árbol, no ven el bosque. Y los políticos tienen que empezar a ver el bosque y no solamente el árbol.
As a matter of fact, one of the first associations that joined us was the Nurses Association.
Eso lo que quiere decir es que no solamente hay demócratas y republicanos, pueden haber otras cosas.
And then we have the politicians.
Bien importante en esta ecuación la labor y la colaboración del compañero George Grisham en el proceso de mover el proyecto en la Cámara de Representantes de Puerto Rico. Y George estuvo con nosotros en ese proceso de cabildeo, de buscar el espacio, ¿verdad? Y de que vieran que teníamos un hermano mayor con poder o con fuerza, si uno le quiere llamar de esa manera. ¿Por qué no? Con fuerza. Porque los de aquí miran hacia el norte pensando que los del norte tienen más grasa. Claro que tienen más grasa. Tienen más power también desde el punto de vista, ¿verdad?, de acción. Pero vamos a tener también los puertorriqueños que aprender que nosotros necesitamos de los hermanos del lado de allá. Pero nosotros debemos tener la capacidad de nosotros poder resolver nuestros problemas, porque tenemos la capacidad para hacerlo.
George Grisham came down and helped us, really helped us, because we were presenting a project for the Health Association, and he came and backed us up. This project is what you might have seen there. It's called Project 1185. This is to build a no-fault, an insurance program, health program, just as many of the different countries throughout the world have.
Bien, nosotros dimos una conferencia de prensa en Nueva York para hablar del 1185 y fuimos a Nueva York para dar a conocer, ¿verdad?, lo que estábamos haciendo en Puerto Rico, que Puerto Rico no es el jabo nada más. Puerto Rico no somos el rabo nada más. Eso quiere decir que los puertorriqueños también tenemos la capacidad de pensar y soñar y tener esperanza, como lo puede tener cualquier otro ciudadano del mundo. Y fuimos a Nueva York y como cuestión de hecho se utilizó como elemento de catapulta o de impulsar lo que estábamos haciendo en Puerto Rico. El 1185, nosotros, lo de la alianza, hablamos de un sistema universal de salud, mas sin embargo el 1185 no habla de un sistema universal de salud, habla de una gobernanza participativa donde estarían sectores diversos de la sociedad, incluyendo, por supuesto, las casas aseguradoras, los médicos, los hospitales, participando todo para tratar de empezar un proceso para mover esa cadena que tenga como resultado primario algo que ustedes plantearon en el mensaje que usted dio, empezar con eliminar los intermediarios y tener un solo pagador, empezar por lo más simple.
1185 wants to get a multi-sectorial group of people to really work on a new program, health program. That's what we really are looking forward. 1185 wants to get a whole bunch of people of different sectors, physicians, nurses, whatever, getting together and working this problem out. Since 1993, we've had problems here. We are getting nowhere. And the thing that we can do right now is get together a group of people to work on this. And that's what we really want you people to help us out. This 1185 went through the legislature and passed with flying colors. Now it's on the Senate floor. And we have to put pressure. But since we have the insurance people putting pressure against it, then we have to have people like you helping us out to see if we can get the 1185 going. If we pass 1185, I'll tell you one thing, this would really help you too. Because the more progress that we get, the better off you are. Because you can get good ideas from this program. So please help us out.
Para concluir, yo he tenido una ventaja, ¿verdad? Y es que he consumido quizás mis 10 minutos en español y 10 minutos más en inglés, ¿verdad? Es una ventaja quizás sobre ustedes, ¿verdad? Pero antes de concluir, quisiera dar una expresión muy personal. Uno lo que tiene es una sola vida, por lo tanto, puede ser que yo el año que viene no esté con Papito Dios, ¿verdad? Y no esté participando de Somos el Futuro. ¿Cuántos de nosotros tienen que pasar por esto para que haya la voluntad de cambio? ¿Cuánto? ¿Cuánto tiempo más vamos a esperar? Yo escuchaba a Minerva, ¿verdad?, hablando en inglés, pero tenía a Gold traduciendo lo de Minerva, ¿verdad? Y muy pendiente, porque Minerva es fogosa. Es una mujer muy fogosa. Y me agrada esa fogosidad de Minerva. Pero me preguntaba yo, ¿y la opción son los demócratas? ¿Y por qué no empezamos a enseñar a los demócratas que pueden haber otras opciones para que nos tomen en cuenta verdaderamente? Para que nos tomen en cuenta verdaderamente. Porque los demócratas tenían el Senado y le temblaron las rodillas para manejar la cuestión de la inmigración. Temblaron las rodillas a los demócratas. Y tenemos que empezar a también enviarle mensajes a ellos, los latinos, empezar a enviarle mensajes de que si ellos necesitan el voto latino, tienen que empezar a asumir un rol más protagónico en defensa de los latinos, porque es la comunidad que está creciendo. Coño, y a última hora somos los latinos los que estamos, claro, además de los americanos, porque hay muchos americanos buenos también, y americanas también buenas. Pero somos los latinos los que estamos creciendo. Y somos los latinos los que vamos a trabajar y ganamos menos también. Gracias a todos y todas. Que Dios los bendiga.
What a way to end the conference. Whew, I'll tell you. Wow. I'm going to invite you to some of mine. We're going to open now the floor to questions. If you have any questions on anything that was said, I think they did a dynamic job of presenting their different perspectives. And now we'll field your questions. Any question? Wow, you guys did a great job. Well, I'd like to say something. I think it was really, really excellent. I was very proud to be here, sitting here with you while you presented. I think all of you gave a little bit about what CMS, started out with the 3 aims: better health, better care, lower costs, and each of you touched on something about the 3-AIM program, and I really, really appreciate it. I was taking notes because I'm taking it back to my peers in New York, and I really want to thank all of you for being here. I hope to see you in the Virgin Islands. And I want to thank you, too, for hanging out with us till the end, and even though it's cold in here, we really appreciate you being here. I appreciate being here, and thank you so much.